I want to thank the organizer of this international conference for the opportunity given to me to present my work, which is Prevalence of Thrombocytopenia in children infected with malaria in Ilorin, Kwara State, Nigeria. These are my outlines. Introduction. Malaria is a blood parasitic disease that is caused by protozoans of genus Plasmodium, and they are transmitted by female Anopheles mosquito. The different plasmodia are not uniformly distributed throughout the world. We have P. vivas predominant in Asia and falciparum in Africa. Severe malaria is associated with a high mortality and reported as the fifth case that causes death from other infectious disease in the globe. Malaria does not only reduce platelet count, but also compromise the function of platelets in complicated cases. Platelets play an important role in coagulation and autoimmunity. Hematological abnormalities are the most implicated complications in severe malaria infection, and they play a major role in its fatality. A normal platelet count is 150,000 to 450,000, and the decrease in platelet count can result to bleeding from the mucous membrane, nose, central nervous system, etc. It can be classified as severe at a count lower than 20,000, moderate within 20,000 to 70,000, and mild 70,000 and above. The drug of choice, parasite density, existing hemoglobinopathy, demographic factors, nutritional status, and malaria immunity are factors for hematological complications seen in malaria infection. These are the factors that result to the hematological complications we see in malaria infected individuals and children. Thrombocytopenia seems to occur primarily by peripheral destruction of platelets, bone marrow alterations, excessive destruction of platelets by the spleen through anti-drug antibody interactions, and platelet consumption by the process of disseminated intravascular coagulopathy. And the mechanism of thrombocytopenia is further justified by destruction of platelet by IgG antibody through anti-drug antibody formation, release of adenosine diphosphate by hemolyzed parasitized red blood cell. When the parasite invades the red blood cell, it lyses the red blood cell and destroys the red blood cell, and the process adenosine diphosphate have been released. This megakaryopoiesis, direct lytic effect of the parasite on the platelet and oxidative stress. Malaria is endemic in Nigeria with about 53 million cases and 81,640 deaths annually. Children under 5 years of age accounted for about 80% of the deaths, and the children have low immunity. This makes them to be susceptible to malaria infection and its complications such as thrombocytopenia. 4 African countries accounted for just over half of all malaria deaths worldwide. Nigeria was accounted for 31.9%, the Congo 13.2%, Tanzania 4.1%, and Mozambique 3.8%, according to World Malaria Report in 2021. According to World Malaria Report in 2020, in 2019, we have 227 million cases of malaria infection and 558,000 deaths. And in 2020, it was skyrocketed to 241 million number of cases and 627,000 deaths. This is my methodology. A total number of 100 samples were collected from malaria parasite positive patients of 5 years and below, as diagnosed by GIMSA staining technique for both thick and thin blood film, according to Che 2007. So we made thick and thin blood film for the patient to examine them for malaria parasite. 30 samples were collected from apparently healthy children of 5 years and below who were negative for malaria parasites as control, and the subjects were patients admitted into the wards of Children's Specialist Hospital Center Ilorin, Kwara State. 50 were male and 50 were female. We maintained gender balance. For the subject, it was intentional to maintain gender balance for balanced analysis and report, while 15 were male and 15 were female for the control. Sample size was determined using sample set determination according to Cochrane 1977, and about 2 ml of whole blood were collected from each patient and controlled through venipuncture technique. A thick and thin blood film were made for each patient and control for the examination of Plasmodium falciparum in their blood sample. The rest of the blood sample was transferred into dipotassium ethylene diamine tetraacetic acid EDTA bottle for determining the platelet count, And the platelet count was analyzed using URI D41 hematology autoanalyzer, while the statistical analysis was done using statistical analysis for social sciences 70.0 software. These are my results. Table 1 shows the social demographic indices and the level of thrombocyte in hospitalized children with malaria and control in Ilorin. As you can see, the age, we have those who fall between 1 year and below. Under the test, they account for 15%, and under the control, they account for 14%. That's 15 and 4 respectively in numbers. For those who falls within 1 year to 3 years, they accounted for 50% and 43% for control, and we have a number of 50 and 13 respectively. And those who falls within 3 years to 5 years accounted for 35% and 43% for control, which is 35 and 13 in numbers respectively. So the gender is between 50%. Having examined the blood sample for malaria parasite, we found out that those whom their parasite density fell within 300 downwards parasite per microliter accounted for 45%. Those who fell within 301 to 800 parasite per microliter fell within 34%, and those whom the parasite density fell within 801 to 4000 parasite per microliter fell within 21%. Table 2 shows the prevalence of thrombocytopenia in children infected with malaria, and in our analysis, we find out that 70% of the malaria-infected children had normal thrombocytes, while 30% had mild and moderate thrombocytopenia. Table 3 shows the mean and standard deviation of the age and platelet count in children with malaria and children who do not have malaria. So we compare the mean and standard deviation of the platelet count of those who had malaria, our test subject, and those who do not have malaria, which is our control. So there was no statistical difference in their age. As we can see, they are all 5 years downwards. And the platelet count, we can see there is statistical significance difference in the platelet count of the test and the control, as the mean of the platelet count of the test is statistically low to the mean of the platelet count of the control, and there is statistical significance according to our p-value. Table 4 shows the degree of thrombocytopenia among children who had malaria based on the degree of malaria parasitemia using one-way ANOVA. So we, having carried out the malaria parasite examination and graded them into malaria parasite density per microliter, we now analyze the platelet count for us to see if there is statistical difference, and we find out that there is statistical difference in the platelet count in respect to the severity of the infection, which is expressed in the malaria parasite density in the blood sample. So we find out that the higher the malaria parasite density in the blood sample, the lower the platelet count. As we can see, the lower in the mean of the platelet count as the malaria parasite density increases, as is shown in this table 4. Discussion. My table 1 shows that the age of the children used were of the same age range, and there is uniformity in the gender based on this as selection for the work. And there is 30% prevalence of thrombocytopenia in malaria-infected children in Ilorin compared to 23 to 59.7% carried out, by Akínbọ́lá et al. In 2006. The decreasing in the level of the thrombocyte is directly proportional to the severity of the malaria infection, as seen in the analysis of variants conducted, shown in table 4. An ingestion of malaria drugs like quinine has been discovered to result to anti-drug antibody formation that binds to a glycoprotein on the platelet surface, which results to its clearing by reticular endothelial system. There is also drug antigen antibody response. All these contribute to thrombocytopenia in malaria-infected children. In table 3, there is significant difference between the platelet count of the test subject and the control, which indicates that the platelet count is lower to the control, and this is as a result of the complications of malaria parasite and a further justified previous studies. As indicated in table 4, the increase in the malaria parasite density is directly proportional to the reduction in the level of the platelet count, and there is also statistical significance in the difference. In that same table 4, we could see that there are some of the children who had higher malaria parasite density yet abnormal thrombocyte level, even though the numbers, was not significant. This may be due to differences in human reactions to drugs, variations in treatment duration, as we can see that all of them are admitted into the hospital and they were not admitted the same day, compliance with drug therapy, and innate immune system. Destruction of platelets by hemoglobin G antibodies through antidrug antibody formation, release of adenosine diphosphate by immunized parasitized red blood cells, dysmegakaryopoiesis, direct lytic effect of the parasite on the platelet, and oxidative stress may contribute to the result of lower platelet count observed in a study. And the previous studies also corroborate this study as it reveals to earthward what is obtainable in Kwara State, Nigeria. These are my conclusions. There is 30% prevalence of thrombocytopenia in children infected with malaria in Ilorin, Kwara State, Nigeria. Platelet count should be considered in determining the severity of malaria infection, and further studies should be carried out, to validate the utility of platelet count as a marker for malaria severity. Recommendation. These are my recommendations. More attention should be paid to the prevention of malaria infection in Ilorin City and Africa at large, and malaria-infected children should be monitored on thrombocytopenia because of its attendance risk. Health non-governmental organizations can invest in donating malaria infection prevention materials to villages in Africa out of goodwill. Thank you. These are my references.